his spiritual son. So he's my father in OI. We are here in November of last year in the end of the world in the Patagonia, Argentina. So let's start to say something about bone density, because all these fragile bones start with bone density. So the bone density, this is the graphic of the bone density of normal persons that reach the peak at 80 years and then goes in a horizontal line and then goes down after 50. That's normal. And that's could be a person with a rickets, but the person without OI, the expectation of life is less. So it goes maybe between 30 and 50 years, depend on the classification of the OI. But what I want to say here, that I would like to change these lines, the red put it in green and the green put it in blue. That's the goal, to improve quality of life of the patients. Osteoporosis, you can see in different problems, but osteogenesis imperfecta is for sure is one of the worst. The worst osteoporosis. To treat osteoporosis or to treat patients with OI, you need a team. You need all these doctors and technicians around the patients, and the best thing is to have all these people and professionals in the same building around working around the health of the patients. Classifications, which the ones I like, is very simple. Is mild, very soft OI, then the mild, then severe, and the lethal one. So 1, 2, 3, 4. These are classifications of 2014 of Van Dyck and Silence. Silence have a old classification that we use also, and there is like more than 20 different types of genetic, but for surgeons, this classification of Van Dyck and Silence is very practical. I like to tell the parents that the bone is like a column, and the column, that's made of a scaffold of iron and concrete. When you mix all this, so the structure is very strong. But if one of these is weak, like in this case, the collagen is the iron scaffold. So if you have a bad iron scaffold, or you have in the bone a bad collagen, so you have a weak column, and the column can break. If it breaks, so you have to put a cast or some immobilization, and then you have a secondary osteoporosis. So we have to break this circle to improve quality of life. So what I'm going to talk today is about surgical solutions. But to start with surgical solution, the first tip is to know the medical treatment. So you're not only a surgeon, you have to know about the sickness, about osteogenesis imperfecta. You know that good nutrition with vitamin D and calcium is important for these patients. And some patients have to have a supplement of vitamin D. The use of biphosphonates, like zoledronic acid or palmidronate, is important. So I always follow the protocol of Dr. Gloriex from Montreal. The sun exposure it's important. It's only 10 minutes a day or 20 minutes, 10 to 20 minutes a day. It's important to the vitamin D function very well. So let's start now with surgical considerations. So we can correct with osteotomies, or we can correct by guided growth. Most of the apex of the deformities are not artificial, but sometimes the patient needs a plate with my preference is the ones that are flexible, like this one, a hinge plate that had a flexibility. And this is the idea of Dr. Danny Green from New York, my friend also. So this tension band, like Peter Stephen named it, he's the father of the idea of tension band concept and guided growth, It can work for a cora like this, a cora or apex. In this case, is a lack of extension of the knee. You can use it. I use it in this case two, like you see here, two hinge plates in this case, and it works. And the other cora is here. So valgus of the tibia. You can see with the test you do with a panoramic view of the lower limbs, and here now you have correction, because do correction of the coras that are in the epiphysis or on the metaphysis is very difficult. So if you can use guided growth, better. But we're going to talk now about rodding. Why rodding? Because the nail support the bone that is weak. It's like steering effects. So you can guide the bone during the growth, and you can reduce the rate of fractures. And if you have a fracture, it's going to be less difficult to treat it because there's displacement is less. Always plan. The planification, the plan of a surgery is important. You can do the plan with the X-ray, and you're going to have a very good idea where you're going to do the osteotomies. You need an AP view, and don't trust only one view. You have to, like everything in orthopedic, you need the other one. And here you can see that it looks like a good alignment, but when you see the lateral view, we have antegrade and a big one. So we have to follow some rules to do osteotomies, and I like these rules. Rule 1 is a rule that says if you do the osteotomy in the same place where the cora is or the apex, so there is no displacement or translation, okay? But if you do the rule 2, if you have a deformity and you do the osteotomy in the upper part or down part of the cora, you're not doing in the cora. So, in this case, in this picture, you can see that's down the cora, and we are going to have a translation, but these translations are going to be correct. I'm going to give you an example like this one. Here's a patient with a oblique plane. You can see in the AP, you can see a varus. And kind of a lateral, it's not a perfect lateral because I have an external rotation. It's very difficult to do a lateral patient that have a rotation. But with these two, you can see there's an oblique plane. So it's anterolateral curve. So it's a oblique. But we can do a plan with this. So here in the blue line, we have the axis. Oh, yeah, you have the axis of the proximal part, anatomical axis of the proximal part. The green is the anatomical axis of the distal part. So we have one cora here, but this cora, we want to put it in two. So we draw the next line. So we're going to have two coras. So we can do two osteotomies. Okay. So what we want to do is to put it straight, in this case with a telescopic rod, a fasciae, and then see what happened here. What was wrong there? What it fails? Because they started in a wrong entry point. So if you remember, you place the nail in the anatomical axis. Have to go from the piriform fossa, and then you do osteotomy and go straight to the middle of the knee. So this is the cora I use in this case. I didn't use these two. I could use it too. There's another technique. You have a pseudoarthrosis, a rigid pseudoarthrosis here, and you have another rigid pseudoarthrosis. So I prefer to do osteotomy using the middle, a little bit up of the first cora, and then we have osteotomy, the side of the osteotomy with the rule 2. So it has to be translation, a little translation, because we're very close to the first cora. Okay, so we're holding the two pseudoarthrosis and the osteotomy, and it works nicely. We have to know the instruments, and it's very important to know one of the tricks of these instruments is that the reamers are oversized. So if you ream 3.2, you're not reaming 3.2, you're reaming something more enough to feel the nail goes smoothly. The position of the patient, Dr. Fassier taught me these positions, nice. I mean, it's not it's lateral. It's kind of a middle between lateral and supine. It's like 45 degrees of, in like an oblique position. So it's very nice because you can see this hip and then you can see the other hip with the C-arm. The right table and the right C-arm and your best friend in this surgery is going to be the technician of the X-ray. So the technician have to know what you're doing and what are the positions you need to orientate the surgery. And the teamwork. Here in this picture from Saudi Arabia and 3 different hospitals with all my friends. And all these guys were learning OI and the nurses, they do a great job, but they have to know what we are doing and they have to know how the instruments work. I like to draw, I like it. So I like to draw, first what I do, I draw the patella. So that gives me during the surgery, orientate me the position of the leg because the deformity is so crippled like here. So I like to draw the deformity because I do this surgery. Sometimes I do it sitting, so I can see the lateral perspective of this leg. I like to draw the incision also. That's another big advice of Dr. Fassier. Don't use oscillating size. You don't need it. You can cut the bone normally with a ronger, or you can use a drill and osteotomy. You don't need to. The size it hits the bone and kills the surface of the bone. So don't use it. These slides belongs to Dr. Fassier talks. It says if you have a difficult reduction, then the main reason is a soft tissue tension. So check with an anesthesiologist if the patient is paralyzed, or it says shortening. I don't like to say the word shortening, but it's a shortening. But I like to substitute this word for osteotomy, because you're doing osteotomy, you overlap I'm going to show later how do we do that. You overlap the bone and then you cut it. It's not a shortening because the real length of the bones is going to be longer. So it's like a shortening. You're taking out bone, but the bones are going to be longer. So I prefer the word osteotomy. And he say, don't fight with OI bone. You will always win a fracture. Like in this case, you have a huge deformity. So you have to do osteotomy to overlap I do osteotomy, I overlap, I take the bone enough to have the bone as long as the soft tissue, and with the soft tissue with tension enough. In this case, we could do lengthening of the Achilles tendon, but I prefer to do osteotomy of the tibia. When you do a percutaneous way, I did a paper of my own job, and the percutaneous is less than 30%. It was like 28% of the cases. And you can do it only in very easy, I mean, not easy, the angulation is a small quantity of degrees. Not difficult cases really. The bone, remember, the bone is weak and flat, so let's say the sword shape. I always say that the telescopic nail is placed in the anatomical axis. In the femur, goes from the piriform fossa to the center of the knee, and the center of the knee to the center of the ankle, and the tibia. Very careful with the entry points. The entry points is in the anatomical axis, like I told you. So if you did a mistake, go back and do it again. Don't, because you're gonna create a deformity. In the proximal femur, what I like to have with the C-arm, this image, I draw with a K-wire a line from the center of the head to the tip of the trochanter, and I go perpendicular to this line, and my nails are gonna go that way. So here, now I can have cervical shaft angle right with this little trick, and I can correct the valgus. Sometimes you have to do osteotomy of the tibia. That's not very common. Normally it breaks when you do the osteotomy of the tibia, and you can break it with your hands also. But sometimes the fibula, especially in type 1, you have to do osteotomy. In this case, I do it with very small incision, like a percutaneous osteotomy. You can do antegrade or retrograde. And here I can tell you this thing is very important. You can see here a Kelly clamp or a snap. You see this snap here holding a K-wire. This is the guide. So the guide, I like to hold it with this clamp. Remember, right here is the sciatic nerve. And so you can hold the guide here so the guide don't hit the sciatic nerve. And then you can retrograde. How to measure the female components for cutting? That's very important. Once you place the male, okay, you go back with the instrument that's calling it's an instrument to go with to go back and hold the male in place. So the male is going to be very long, okay? So you put another male of the same size, same diameter, and same length. So you put it, this is a concher nail trick, okay? So you put it like you're seeing here. You put it backward. You put now another Kelly clamp here, and then you can put your female parallel to the nail you're using to measure. There is a wings of the system. So from the wings, I cut it 1 centimeter. All the time, I cut it 1 centimeter more. That's what I call the surgical mistake. If I do a mistake, it's because it was shorter. If you do a mistake because it was longer, that's a nightmare, because you're gonna push the male into the joint. And so that's my advice for the way to cut it. Here I'm cutting with the right instruments also. The instrument have a cutter. Is very nice, but for small patients, maybe you have to cut it with the normal cutter. Check the smoothness of the cut, because sometimes bends. So you have to be very careful you don't have these things bended, because it's not gonna telescope. Okay, let's talk now about proximal third of the femur in Osteogenesis Imperfecta. The proximal third of the femur, I mean, the femur is a bone very different to other bones, because somehow in the evolution we stand up, and because we stand up, the proximal part of the femur is different to other animals. So we save a lot of energy with this design we have, and that what happened now is that we have weak point. We have weak point in the neck. We have a weak point in the lateral cortex, and we have another weak point in the subtrochanteric area. This article of Journal of Mechanics, and they found in OI patients that these three. There is also 4 points, because there is a weakness in the metaphysis of in the union of metaphysis with diaphysis of the distal third. So, do fragile bone needs intramedullary nail? Yes, because the collagen deficit makes bone fragile, and the bone must be protected from epiphysis to epiphysis, from the, remember, in femur and in tibia and in humerus, should protect from epiphysis to epiphysis, thus to avoid fractures and displacement. Due to the new treatment in OI, better quality of life, okay, and better function and more activity. We have more activity, more exposure to mechanical forces, more injuries. In lower limbs, the proximal third of the femur is the weakest point. So Dr. Richard Cruz from Alfred DuPont Hospital asked me to write a chapter about proximal femur and osteogenesis imperfecta. And with these two friends, Carlos Pargas, who is working now on DuPont Hospital, and now he's going to go with to Baltimore with Hessenberg, and Alfredo Santana. With these two friends, we wrote a chapter, and we found 3 types of deformities of the proximal femur in OI. In the type 1 is a subtrochanteric oblique plane, okay? So that's the most common. The type 2 is a deformity in the neck, and the type 3 is a weakness of the lateral cortex, and the deformity goes like this. I'll show you one by one. So the type 1, we can have anterolateral, which is the most common, anteromedial deformity, or posteromedial. That's the three types of the type 1 we found. Here is a diagram of how the deformities show. These are lateral view and this AP. So you can see a real oblique plane. You can feel it. You can palpate with your hands the deformity. It's the most common. The deformity apex or cora is an anterolateral direction, and also have external femoral torsion always. This is the duration of the deformity, and the type 1 usually is palpable. Internal rotation, abduction, and flexion movement are limited, and in some cases resemble a coxa-vara, but like Dr. Fassier wrote in a paper, he called it falsa coxa-vara or false coxa-vara. The apex or cora is subtrochanteric in the type 1. That's the most common one. You can see it all very common, and we're going to talk about this, how to solve this with a surgery. And now you can fix it like this. Here's another example of the anterolateral. This is type A1. And is with a nail. This is a patient of 14 years old with a nail in. He has like 5 years with that nail, and it breaks. It was a deformity already, and it breaks. And we use in this case we use a gap nail. A gap nail is not telescopic. This patient is 40 years old. He stopped growing. The faces are closed. And here is the nail with this a very fantastic structure. We can hold the proximal femur and lock it. So it's very nice. Difficult to use, but very, very good results. And type 1B is the anteromedial deformity in the subtrochanteric area. It's less frequent and less obvious in the clinical. You can palpate, but it's in the back. The bump is in the back of the thigh. The 1C is a posteromedial deformity at the subtrochanteric area. It can be observed in OI type 3, which is very, very not frequent. And 1B and 1C type have a history of being treated due to a fracture by orthopedic reduction. Now we're going to talk about type 2. Type 2, we have the type 2A. This is a cervical deformity. Affects the cervical shaft angle. The deformity is a true coxa-vara. It is more common in patients that had surgery on the femur shaft with the aim nail. So you can see it, patients that have a nail, and the only weak point is the neck. Now, because we put a nail before. So the neck is unprotected, like in this case. All these cases had. So to hold this problem, you can do it with this technique of Dr. Fassier in an article, Dr. Fassier and Gloriex. You can see K wires holding with a wire here around with a circlage. That's one way to do it. This is the Fassier technique. We found only 3 patients with this type. We can have a fracture of the neck without having the nail. But these patients always have a huge external femoral torsion. So my theory about this is that the external torsion is so big that the neck impinge the acetabulum, and the patient could have a fracture, like in this boy of 6 years old. Here, it doesn't look like a fracture, but you can see this line. And days later, we could see it was treated for another guy. So they could see a fracture, and they treated like they didn't know the patient was OI because it was a mild OI. So they found a fracture here, and they put 2 screws like a normal patient. So what happened? The patient have a pseudoarthrosis, and the virus was in progress, more and more pain. So, and we found another deformity here, very common in OI, this deformity here. So we have to hold this part, and we'll do another osteotomy here with the nail. So we could use the Fassier technique, but we prefer to use a customized device with this company, TechFit. And we did a plate with arms that will hold the bone, doing 1 osteotomy here to correct this coda. And here we did another osteotomy to do a valgus osteotomy, putting a Fassier dual nail and the plates. And there was the prototype of the system, and we did the surgery. We put the nail, we put the plate, hold the whole thing, and it works. Now we have the 2 osteotomy heels, and 1 month ago I took out the plate, and I left the nail because the patient needs the nail. But now we have a normal shaft angle. In the type 3, it's not uncommon. It's more common if you do a mistake with the entry point. So it's a weakness of the lateral cortex, and the nail, the virus is going to be huge. It's going to resemble a congenital problem, but it's not. I mean, it's the nail, instead of go through piriform fossa, once do the big trochanter lateral part, like another nail. So you create a problem. We call it the type 3, which is a fracture of the big trochanter and lateral corset that could be caused by failure of the entry point. How can you solve this problem? Now we have a cosa vara, we have a fracture here, and this is holding nothing. So we have to go through the piriform fossa, do the osteotomy here. Now I place the nail first, and to hold rotation, you can hold it with a plate. This plate is supplement. I mean, you're gonna put the plate, and you have to take it out in 3 or 4 months. That's what I'm doing. You have to take it out, because once this heals, you don't need this plate. About the approach consideration, the proximal femur. First, it's position. Then you have to draw the deformity, and you have to draw the approach. Then we have here the muscle. We have the muscle here, This is the lateral vastus. You can see the lateral vastus, and we have to cut here. Okay, the first thing is a lateral and posterior approach. Once you see the fascia lata, you have to cut the fascia lata just in the place where we're finished. Then we do incision here. We take, I'm gonna show you a picture now, a movie. Okay, and when you see the vastus, you have a little cut here. Okay, like here. This is a little cut in the vastus, and now this is the fascia lata, iliotibial vein, and this is the vastus. Okay, and now we have the deformity. Okay, then we expose the bone without taking out the periosteum. You overlap. Once you overlap, you cut the distal part, because you need, the one you need long is the proximal one. And then you put the nail with the technique, okay? So let's see this patient. This is the right, and this is the left. We're gonna do the surgery here in the right. And then we have this very big deformity. This is the patient, the OR. This, I draw the deformity. You see the skin incision is a 90 degrees. You're gonna see what happened. Here is the fascia lata here, and here is the muscle. I did a cut here, and what you're gonna do, see, I like to use the Kelly clamp, the snap, to do this maneuver. You can see here. Okay, now, see the head here. Here's a very almost 90 or more than 90 degrees deformity. And I can expose the whole bone without only cutting one muscle. Okay, this is a deformity. Now, I overlap, I cut whatever I have to cut to put everything straight. And I prefer to cut in distal part when doing the osteotomy in the proximal part. I'm going here retrograde to the peripheral fossa, antegrade to the distal part, I ring both, and I can put, and here I'm gonna have a translation, but the mechanical axis is gonna straight, and the anatomical axis also. So I have my bone straight, and see the incision, remember, was almost 90 degrees, and now it's slightly almost straight. Here is another example, same deformity, very common, and here's the maneuver. So I'm doing here 2 homins, and now see, it's like a peel in a banana, and see the periosteum is safe. Okay, it's very important, this consideration, the femoral anteversion, because if you're going to use a plate, or when you finish the surgery, you're going to put a cast, you have to know what anteversion you're going to leave. If you're going to put a plate or a gap nail, so you have to know that here you have the direction of the neck, because you can put a K-wire just in the middle of the neck, and here this wire, I'm signing here. This wire is in the axis of rotation of the knee. So remember, the anteversion is the angle between the axis of rotation of the knee, or a line that goes on the back part of the knee, and the axis of the neck. So this angle, you can see it here. If you're going to put a plate, you put these 2 wires, and then you can put hold it with a plate to hold the whole thing. And if you're going to put a cast, you have to remember what is the right position. So the longer proximal fragment holds is better. Once we do the osteotomy, we have to overlap the proximal and the distal fragment to measure the osteectomy. This way we can avoid tension of the soft tissue. About surgery, type 1 FD nail is the golden standard in patients with open physis. The type 2 valgus osteotomy can be stabilized with a supplement, which could be a K-wire as a fascia technique, or I prefer a plate, a locket plate. And in adults, I like to use the gap nail. In the type 3, solutions like in the type 2, it's important to hold the neck and the trochanter, but in this case, the lack of the lateral corte of the trochanter makes it more difficult. So the locket plate in children's use it as a supplement, is an option, and the gap nail is an option in adults because we have a assembly structure. So in conclusion, in lower limbs, the proximal femur is a weak point in fragile bones. Telescopic nail is a gold standard for children's. Locket plate is a supplement. You cannot use it alone. The intramural locking nails are option patients with physis closed, and the gap nail is ideal because it comes in small diameters and the design is made for fragile bones. So the purpose of these classifications is to clarify the different deformities of the proximal femur and OI, and the purpose of this chapter of this book was to propose a plan to correct. And that's the first part of my lecture. In Arab is a shukran, but I'm gonna give you some tips because I have more. I make this talk to give it 40 minutes. I have 45, so I have 5 more minutes. Look at this. This is very weak. What can we do here? This patient have a lot of pain, so we can place. Can we do something with that? Because it's very weak. So what I did, I place a FD, I hold it here, I went out of the bone because nothing can be placed here, and hold the other. Okay, looks like a popcorn bone. This is a very difficult case. So I did the same on tibia, okay, holding the calcaneus. And you know why? Why I did that? Because the pain. These patients stop to have pain in lower limbs. So that was very nice to see the patient could sleep. So that's another thing. Some words about spica. I don't like spicas. I prefer to use a soft cast. Or A-frame cast. If in tibia, you can use a cast in tibia because if you flex it, you can hold the rotation. Let's talk about now adults. Some words about a patient with a small bone like this one. Is a patient with OI, 20 years old, and now we have a 6 millimeters diameter. What nail I'm gonna use here? There is no nail. There is one, but it wasn't. So now we have a gap nail. That was an idea of Pegamedico, Galvan and Parra. That's why we call it gap. And with this nail, we can solve a problem like this. A patient 40 years old, I showed you before, and we could solve the femur or the right femur with this nail, 5.6 diameter, and then he got a fracture in the left, and the left we could do a different assembly, like here, and we could lock it. The patient was very happy because the patient doesn't need a cast. So it was a fracture, and it needs another osteotomy to put it straight. So in 3 months, we had a heal of both. Each one takes 3 months. So it's the patient moving. This is another patient from Lima, Peru, with a very difficult deformity. Okay, so we did a technique of super hip. I learned with Dor Paley to correct this deformity, but I treat it like a congenital deformity plus the problem that is a very fragile bone, like you see here. So I did some cuts I designed, and I hold it with with a gap nail. I could lock it, and I did a chiari technique to have to put it straight. And I did this teres ligament to hold the hip in place. That's very interesting. 36 years old. He came to emergency room with a fracture. See the height of the patient is 1 meter 10 centimeters. It's a very, very small patient. It was a very small bone and got a fracture. See the arrow here. You can see a fracture of the subtrochanteric part. And the patient had a plate. So I had a fracture just when the plate finished. That's why you don't have to use a plate alone. So I let the plate, I took the screws out, and I put a gap nail. So, and here you can see the gap nail locked. So the patient, she didn't need a cast. Here is another patient of 80 years old with a deformity. I use a gap nail also. So the nail design, or the gap nail is designed for weak bones and bones with a small diameter. So in conclusion, the fragile bones with deformities, you can correct it by guided growth, or you can correct it by nails. The nails in children, I prefer the telescopic one, and in adults, the gap nail is a good option because the diameter and the design. Now I finish. I have to say thank you to my friends in Saudi Arabia, and now I'm ready to answer whatever you want to.
Thank you, Dr. Thank you, Dr. Miguel. It's a very long talk, I know. It's very heavy information, and always we get tricks and tips and advice from you that help us and facilitate treating those poor kids. Thank you very much. And I believe Dr. Faser is here. If we can, I would open the mic for him if he would like to give a comment. Dr. Faser, the mic with you.
Good afternoon.
Good afternoon.
Hello.
Congratulations, Miguel, for this excellent presentation. If I may add one thing, in your classification, type 1C, the recurvatum femur, I encourage my colleagues in Saudi, if they see such a case, to check the hip. Because in my experience, most of these cases happen because the patient was born in a breech position, and there is a risk of hip dysplasia associated with this type of deformity.
That's beautiful. Dr. Miguel? Dr. Miguel?
His mic is...
I think it's open. Okay, it's a switch off.
Miguel, unmute your mic.
Yeah. We are listening to you, Dr. Miguel.
Okay, now.
Yes. We are
okay,
listening.
got a problem to unmute. Yeah, that's a good advice. Thank you. Yes, you told me that when we got together in Argentina. Yeah, I haven't seen that, but you have more experience than me. I will take it on account. Yeah, it makes sense, but because these very difficult deformities, I have seen only in patients that had a lot of surgeries before, or fractures, and it's difficult to know where they come from. Normally the patient have anterolateral deformity. That's the most common. That's why it's the easiest to show because it's more common. So we can have technique to correct that. But I have the opportunity to correct this, the 1B and 1C, and that's the surgery is very difficult. So the approach is the same, but you know, the nerve, when you open the fascia and you see the sciatic nerve, this over, I mean, you can see the nerve right away. So you have to be very careful with the sciatic nerve. What do you think, Facier?
Oh, Miguel, I congratulate you because the cases you've shown are extremely difficult, and I would encourage my colleagues not to jump into such a case without, you know, several plans in head. Plan A, what you plan to do, but if it doesn't work, have a plan B, and if necessary, a plan C. And it's very important because in the middle of the surgery, you can't take half an hour to think about it. Everything must be planned in advance. And in such cases, in particularly the severe Coxa-Vara, you have to be ready to do what Miguel demonstrated with the super hip type of surgery that may often be necessary.
Yes, another thing in the type where the type 2, where we have fracture of the neck. Yes, what I saw is that the most of the patients had a surgery before with a nail, even a fascia duval, or it could be any nail. So I think the reason for that is because the nail is doing the job, protecting the diaphysis and the epiphysis, but the neck becomes now the weakest part. Are you agree with that?
I do agree, and it's what we wrote in one of the articles that we published on Coxa-Vara. Most of our patients had a nail put in the diaphysis, and hence putting the neck at risk of fracture. So I always say to my colleagues and my, you know, people who come to visit us, beware, look at the neck shaft angle after a femoral rotting, because if you see that this neck shaft angle is getting lower and lower, protect the neck.
Yes. You protect the neck with the K-wires?
I do the classic technique. You know, if as long as the neck shaft angle is above 110, I don't do an osteotomy. But if it's below 110 degrees, then I do an osteotomy and correct it.
Fixation with what, Dr. Facier?
What do you say?
What will you use for fixation if it, less than 110?
The technique with the 2K wires and the cerclage around. The 2K wires are one anterior posterior going posterior and the posterior anterior, leaving the space in the middle for the nail. You need to have the nail. It's just an adjunct to the fixation.
Yes, that's why I insist that whatever you use, the K-wires, you can use a plate in a bigger bone. I use the K-wires in very small patients, and if you can use a plate, but the plate is, I like to call it a supplement. It's something to, yeah, it's a supplement. It's not a fixation thing.
That's good. And Dr. Galvani will use the plate, isn't it, and screws, and then remove it after 4 months.
Say it again.
You will use, and you didn't use K-wires. You are used to use the plate and screws, isn't it?
Yeah, depend of the size. Some now in this time we have so many sizes of we have a lot of sizes of plates. So I use the K-wires technique, which is very good, but I found since 3 years ago I'm using plate, and I think the plate holds with the locket plates. Now we have the plates with variable angle of the screws. There's one called EVOS, which is pretty nice. And in different places, you can hold it. So if you plan to use a plate, go with a good plate with a variable angle, which is the best, and lock it. Gotta be locked.
I see. Dr. Miguel, Dr. Faser, there is a question from Dr. Tamer. He's asking, how many osteotomies are needed to place FD nail in a normal bone alignment to overcome the physiological anterior curvature or bowing?
Okay, I'm going to answer that, and I would like to hear the opinion of Dr. Fassier. Well, when I did my own revision of my cases, I have to do in femur and in tibia from 1 to 3, but most of the cases, because I start to learn how to do things, the average, it was 2 osteotomies for severe cases. Now I'm not using 3, but sometimes you have to do 3 osteotomies. But that depends of the angulation and depends of the bone. In tibia, which is very tiny and it's not so flexible, you may surprise you need more osteotomy than the femur. When the femur is wider. So, but if I can skip one osteotomy, I can do it. But remember, you can win a fracture. So there's so many tricks to do it in one osteotomy. But if you are not training, so it's better to do one more osteotomy. What do you say about that, Pancho?
I agree with you. I try to do as little osteotomies as possible, meaning 3 osteotomies was for me relatively exceptional. If you choose, as you demonstrated with your slides, appropriate positions for the cora, with 2 osteotomies, you solve 95 to 98% of cases. So in a few cases, you may need a 3rd osteotomy, but I think it's relatively rare.
Okay.
That's good. And another question from Dr. Ali Hashim. He's asking, what's the protocol of bisphosphonate pre-op and post-op for OI patients?
Okay, I like to use the protocol of Montreal, the ones that they use there in the Shriner Hospital. Dr. Fassier is involved in that. Right now, I'm using solendronic acid, which is every 6 months. The dose is 0.05 milligrams per kilogram of weight of the patient. You can do it. You can. The treatment is in 1 hour, more or less. And we have a very good result. Before that, we were using pamidronate, which is a very nice results also. Good thing about pamidronate, when you use it 3 months, every 3 months, you see the patient every 3 months. So you see the patient in the clinic. So you got the control. And with the solendronic acid, it's very good for the patient that lives far away from the hospital, because they have to go only 1 day to the clinic. With pamidronate, the protocol was 3 days for treatment, as it's very difficult for the patient that lives far away. So the solendronic acid is working. The numbers are really good. Pancho, what do you have?
Oh, nothing to add. No, nothing to add. We do the same.
Okay.
We prefer Zoll because we have lots of patients coming from far away. So the Zoll is more practical for patients living far away from the hospital.
That's great. Another question from Dr. Muhammad Osman is asking if the male component of the FD nail not gaining or not purchasing well distally devices, then whether to keep it as such, or you have another technique to solve this problem. He asking about the distal purchase for the male component in either femur or tibia.
I didn't understand the question.
Yeah,
it was too long, maybe. Yes, answer that. You can help me.
No, I agree. This is the weak part of the fixation. It's the distal epiphysis.
Okay.
If you leave the threads of the FD nail part in the middle of the epiphysis, you have almost no purchase. It's the reason why when I put the nail, I go down to the subchondral bone, because there the cartilage is thick enough. You don't need to go through the cartilage, but you go down to the subchondral bone, and here you have more purchase of fixation. Same in the distal tibia, and particularly in the distal tibia, the cartilage is very thick at the ankle level, so you can go down almost to what you think is the joint space, but the joint space is much, but the cartilage is much thicker than you can think.
Okay.
Yes, thank you, Professor. And I think, I believe that checking the range of motion after, especially for the ankle or knee, is very important to check for the grinding or the.
Absolutely.
That's good. And another question about the blood transfusion. How many events that use blood transfusion in reconstructing the lower limbs or putting the FD nail for femur tibia? That we know that for tibia we can use the tourniquet for bilateral tibia. But for the femurs, someone of the participant asking about the blood transfusion in OI patients.
Blood transfusion, yeah. Well, when you use tourniquet in tibia, normally you don't have to use it. When I started to work with OI, my professor told me that the patients bleed a lot, and I think it's more or less the same than any patient, but the surgery could be big. So I think if you do the right incision with the techniques I show you for proximal femur, you can hold the whole thing without transfusion, but you have to be prepared for transfusion, especially in femur. You have to be prepared, but maybe not in the surgery, maybe some after the surgery. But you have to be prepared for especially for femur. For tibia, if you use tourniquet, you don't need transfusion.
And do you believe they are easier bleeder? They bleed easier than the other patient, normal patient?
What do you think, Pancho, about bleeding?
Yes, they bleed very easily. Because collagen is everywhere, and it seems that the collagen in the blood vessels may be affected as well. So it's not exactly the same. These patients bleed a lot. And very often, one of the causes of death for this patient is intracranial bleeding. So this is just a rupture of a vessel intracranial.
Okay. I see. And one question from Dr. Mazan, he's asking, when do you stop and restart bimidronate, pre-op, and post-op?
Okay. If you are going to do a surgery, you have to be, I mean, the bimidronate stop the action of the osteoclast. So it's very important to keep 2 months before and 2 months after surgery without the bifosphonates.
May I disagree?
Yeah, it's more than that.
No, it's been proven that the biphosphonates that you inject in the blood is either fixed to the bone or eliminated 48 hours after the injection. So meaning you don't have to stop the biphosphonates very long before surgery. So we go for injection until 48 hours before surgery. But stop. It's very important not to give for 4 months or until you see signs of healing of your osteotomies.
So you don't use it after surgery for 4 months?
Absolutely.
Okay, I have the opportunity to have you here because I have a question for you about the use of bifenthranate because I'm going to talk about congenital osteoarthrosis of the tibia next Monday. And in the recipe of Dr. Paley, he used bifenthranate for congenital osteoarthrosis of the tibia, and he used it 2 weeks before and 2 weeks after. And because I'm using bifenthranate since 20 years ago when I started in 1999. So I'm afraid of using bifenthranate in these patients that are normal patients. I don't see a relationship between the use of bifenthranate in patients with congenital osteoarthrosis. And you're using 2 weeks before, and you can stop the osteogenesis. What do you think about that?
I would be afraid of. I agree with you. Personally, I've never used the bisphosphonates in CPTs because these patients otherwise have a normal skeleton. Their disease is local, not general like OI.
Okay, so we are answering a question for next talk next Monday. Because,
but you know, draw changes his recipe very often. And I don't know if this one is number 101 or 102.
Yeah, that's true. And but I was surprised in one course I was in Dallas, Texas. This guy from Australia, David Little, was using it too in congenital osteoarthrosis. So, I mean, all the experience I have. Dr. Gloria X, since 20 years ago, he's saying don't use it before you're going to do a surgery of OI. And what's the difference in between OI and another patient? It's the same action, isn't it?
But if you give too much biphosphonates, you may induce a kind of osteopetrosis type of bone, meaning a very dense but still brittle bone. So be very, afraid of using it in a normal skeleton. You know what? It's the same question because I know that David Little, the same one you just mentioned, used it in LCP. But you cannot give to LCP patients biphosphonate that's going to act on the entire skeleton while your target is just the femoral head. So you find a way to inject the biphosphonates in the femoral head, not intravenous.
You mean a Perthes disease?
Perthes disease, yes, absolutely. He's been using it.
Yes, that's when I started to use famotidine, I saw a lecture that somebody was using it, and I remember Dr. Bowen, Richard Bowen was in the talk, and I asked him, and he told me, we will never know if this works because there's no way to demonstrate it.
That's great. Dr. Galban, Dr. Fazer, another question from Dr. Tamer. He said, what forces most of the surgeon when they started their career fixing the OI patients to go lateral in their femoral entry is their fear from the AVN of the femoral head? He said, is it almost never happening in the OI with the FD nail in piriformis fossa, as we know?
I will let Pancho, Dr. Fazier, to answer that question because I like his answer.
You know, you may know why Miguel is calling me Pancho. It's a nickname that has been given to me by the South American children. So it's a kind of nickname for Francois, which is my first name. So regarding the AVN of the femoral head in OI, I've been practicing now, but I stopped 30 years, more than 30 years. I've never seen one. And I've done quite a high number of OI patients. I don't know if it's due to the fact that we go very smoothly through the greater trochanter, the fact that we don't use too much reamers that heat up and risk of damaging the vessels, the circumflex artery going to the femoral head. But I had once I was told that there was in Madrid an AVN in an OI patients. So I was going to Madrid the week after. So I asked Dr. Parra to show me the case. And he said, oh, finally, it's not an AVN. So I never seen one.
Yes, I have seen only two. When I was a resident, I saw one was with a puncture nail. That's was a fracture, and it was a 10 years old girl, and they put a puncture nail. But it was a very aggressive technique. Yeah, that's the only one. But I don't have with a fascia dual, with the fascia dual. I don't have one single AVN.
I see.
Did you see one yourself?
Oh, well, no.
I'm asking Dr. Altus. Yeah. Did you see an AVN of the head?
No.
No.
For me, my practice, nothing.
Because I would be interested if one of your colleagues, the people participating to this webinar, has one. I would like to know about it because it would be a case report.
That's right.
Please, yeah, I can tell you, I'm talking about that, there is more problems that I have seen going by the lateral part of the lateral cortex of the big trochanter, creating a very weak point of breaking, putting the fascia dual, like in the case I show you. There's more problems trying to avoid the piriform fossa that going to the piriform fossa. Nothing's going to happen if you do it right.
That's great. And it's very common question and very common scenario that we get in our practice. If we have one patient diagnosed to have OI and get a femur fracture, came through the ER, do you prefer to put a hip spica and treat him conservatively, then later on for osteotomy and FD nail? Or acutely, you prefer to do FD nail at the initial?
Yeah, if I have the opportunity, because in my hospital, the hospital I work, we don't see much emergencies. Normally, the patients call me from another city. So I told the surgeon that live, 4 hours away, and I told him, put a cast, leave it like that, and the patients can fly to my hospital in 2 months or months and a half with the cast, or 3 weeks or whatever. We can make it. But that's the way I do it. But if I have the opportunity that the patient breaks in my city, and I will do the surgery the next day or 2 days after the fracture. But that's not common. Dr. Fasea, what do you say about it?
It depends, on the deformity of the femur pre-existing to the fracture. If the femur is not deformed, I would have a tendency at the first fracture to treat the patient with a spike. But if the patient has already had a fracture and has a femur deformed, then I would proceed directly.
I see. I mean, I'm just my thought. If we treat them acutely So we'll decrease the chance of deformity. The surgery will be easier if we treat them acutely, because multiple fractures treated with the cast, we are not guarantee the alignment will be optimal or that it will be easier. So I mean, more fracture, more deformity, the canal will be obliterated more. So I believe this will be more difficult. So if we treat them acutely, if the setting is allowed, I believe it will be better for the surgeon and for the patient. What do you think, Dr. Fasser?
Oh, no, I agree with you. I agree with you. The problem sometimes is that the fracture does not happen at the level you wish to do your osteotomy. So then you are stuck in a more difficult situation. But if it is the case, I agree with you, it's much faster, much easier. And for the family, it means also, you know, not many hospitalization, immobilizations, etc.
That's true. And a very common question, surgeon asking here, what's the earliest age that you can do FD nailing? I mean, before age of 4.
I like that question. I have a quick answer. As soon as the patient in the femur can hold at 3.2, I'll do the surgery. And that's going to happen between 18 months to 24 months, more or less. If the bone is bended, actually, I mean, you have the indication to do that.
That's great. Dr. Fasser, same thought or?
A little bit different. For me, the indication for surgery is as soon as the child pulls up to stand with deformed bones. You know, we don't operate patients with straight bones. But if the bones are deformed and the patient is ready to pull up to stand, if the patient is 11, 12 months, I would do the surgery. And I've done several surgeries, but generally speaking, it's more so around 18 months that it happens.
I see. I received one patient, his age 1 year and 7 months. And he got a fracture femur before he diagnosed. Then he came to my clinic, already the fracture is healed. He is now 1 year, almost 2 years, with the flexible rods in femur, and he's still not walking. He's non-walker yet. So now between two things, either to remove it quickly and put a FD nail. He's still non-walker. His medulla canal is accepting 3.2, or leave it until he start to walk and remove the flexible rods, which will be difficult and more embedded in the bone, and do for him the osteotomy. What do you think in this situation is better to do?
But the bone is straight now?
Not straight. I have the X-ray, if I can share the screen.
Oh yeah, please.
By the way, Miguel, thank you for inviting me to participate to this webinar. It's very interesting.
Yes, it's you know, this coronavirus gives us the only good thing about it.
It's one of the positive things for the quarantine. See, this is the. Just come to it. You see the X-rays?
Yes, yes.
Ah, that's good. This is the one. Currently, he's 1 year and 2 years, almost. He's reaching 2 years.
Okay, can I see the lateral view of this? Of the femur? Yeah. Well, I have to start saying that the problem with the flexible nails, there's two problems. First, it's not telescopic. So in less than 6 months, maybe 1 year, you're gonna have in the metaphysis, in the distal metaphysis, you're gonna have a part of the femur uncovered. I mean, I said in my talk that we have to protect the bone from epiphysis to epiphysis. Okay, the perfect nail should protect from the head to the knee, but we don't have that. But you have to protect from epiphysis to epiphysis. And this is not happening here, and it's going to be worse in some months. That's one thing. The other is that the elastic nails were made to be elastic and to put it and take it out in as soon as the fractures heals in a normal patient. So because these nails are too flexible and they don't protect the bone. These nails are not internal fixator, okay? So, but right now I leave it. I think I leave it. I think it's straight. They're doing some job, but as soon as the bone, I mean the nail gets short, you can go and change it because it's gonna break. It's gonna have a fracture in the distal part of the femur somehow later on. But right now, it looks nice. I mean, but remember, it's not the correct technique.
That's right. And another case, Dr. Galban, we would like to share this.
May I say something about that?
Yeah,
because
please.
I love this type of case. Because I have one thing that I used to say to everybody who comes to visit me: treat patients, don't treat x-rays.
That's beautiful.
Okay, because this patient doesn't ask for anything. The femur is straight, the patient is able to stand. If the patient breaks again the femur, it's gonna bend the nails. You're gonna have to cut the nails, and it's gonna be much easier to remove the nails
from the fracture site.
From the fracture site.
That's true.
So at this moment, it would be extremely difficult to remove the elastic nails. I agree with your fears, but I would not touch it and wait and see.
Mm-hmm. That's very smart way. And there is one case we operate on her for the tibia. She's 6.5 years old girl, diagnosed genetically and clinically with Osteogenesis Imperfecta. Her tibia was, as you said, the fracture side is easier to remove from the side. But our talk here for the femur side. See, the wall mechanical axis is centered. We see, although the femur is varus, but if you see the line, mechanical line is passing through the knee. And she is having compensating valgus deformity in the distal femur. It's reaching 98. So I believe, Dr. Galvan, if you would comment, Dr. Faser, if we correct this femur, so she will have exaggerated valgus distally. Is that true?
Yeah, you're right. You're right, because but in this case, we would like to you know do a plan. Here there is a apex. I can't sign, but anyway, there is an apex in the middle, in the union of the proximal third and the middle third. There is a chora here in varus, and these varus have two choras, I think. And then there is another chora of valgus and the epiphysis. So in this case, I think I can put the nail and I can treat the distal chora with guided growth, with A-plate or hinge plate or whatever you have.
Medial side.
Yeah, in the medial side. Yes.
Right. Dr. Faser?
I agree 100%.
That's great. And I believe Dr. Ahmed would like to speak with us. Dr. Ahmed?
Yep.
دكتور أحمد.
Yes, hi.
عليكم. أهلا وسهلا. تفضل دكتور أحمد.
Hello.
دكتور أحمد, Turkestani from Jeddah.
Oh, my friend from Jeddah.
Yeah, for King Faisal Jeddah.
Yes, yes. That's the first time.
Hi,
أهلا
Dr.
وسهلا دكتور أحمد نسمعك.
How are you?
I'm very well, thank you. Yourself?
Alhamdulillah, it's nice to see both of you safe, and it's bringing lots of memories.
Yes.
It's nice to see you, Dr. Fasir, Dr. Ghalban. Wonderful lecture and outstanding discussion. Thank you, Dr. Ali, for arranging this. I only want to add one thing, if you let me, Dr. Fasir, Dr. Ghalban. It's something happened with me. As you remember, Dr. Fasir, I shared that case with you. I give one advice to all the surgeons, that if they should screen all the cases for kyphoscoliosis deformity. To keep that in mind when they're planning to do lower extremity surgery. As you remember, Dr. Fasir, I shared my case with you, that boy with a severe lower limb extremity, and he has severe kyphoscoliosis, and I took him for lower extremity reconstruction, and boy ended up paralyzed because of prolonged surgery, supine position and blood loss and hypotension intraoperatively. This is something that I experienced. I don't want anyone else to have the same. And you remember that, Dr. Fasir?
Absolutely. And again, it's a good moment to say again what I just said a few minutes ago. You treat patients, you don't read x-rays.
That's true.
Well, thank you. And good to see you again.
Thank you.
Dr. Ali.
Stay safe.
Thank you.
Dr. Miguel, Dr. Faisal, when Dr. Mazen asking about the staging protocol of you having patient, OI patient, both femur, both tibias indicated for surgery. What's your usual protocol?
I usually, when I have, if the patient needs a correction deformity for both femurs and both tibia, normally I do two bones. I do femur and tibia on the same size. And in another surgery, 3 months later, I do femur and tibia. I know there is some doctors that I really like. They're very good doctors, like Dr. Paul Esposito in Omaha. He tried to do the 4 bones in the same surgery, but because the patient's going to go to the unit care if you do 4 bones, so it's going to need more blood. So I prefer to do 2 and 2. What do you think about that?
I do 2 and 2, but I try to do 2 and 2 1 week or 2 weeks apart, so that the patient will have just one post-op immobilization that's going to be a tiny bit longer, but just one, instead of 2 times being either in a spica or immobilized.
Okay. I see. And post-op protocol, Dr. Faisal, Dr. Miguel, for that, you will put a cast for the femur or a tibia?
Yeah, for I use a lot slabs, braces. I prefer to use braces. I'm trying to do not use spicas if I can. If there, but I use braces made of fiberglass. Prelude is one of the brands I use, and so I try to immobilize with that. For tibia, you can use a slab or you can use a brace also. But because the most difficult thing is to control rotation. For tibia, it's easy to control rotation, but you flex 30 to 40 degrees the knee, and you put the ankle in 90 degrees, and you control rotation with a brace, even with a cast. But for femur, it's more difficult. If I do, maybe you can use, put a stick between the 2 legs as another way. But normally what I use It's a kind of, I have shown you in Saudi Arabia how I do it with preludes with the fiberglass. I do a kind of spica, but it's not a spica, it's open spica. And it works nicely.
That's good.
I hate spikers, so therefore I try not to use that. When I do relatively small children, the tibia and the femur, I use a 3-sided back slab, and I attach them with a tape, the large tape about 2 inches wide. I attach the leg so that there is no automatic external rotation.
I see. That's a smart way. And Dr. Fasad, maybe this is the last question and we'll close. We reached that time. At the end, the distal tip of the male component, there is a hole for the wires. Did you use it before to augment the purchase distally?
I didn't do the hole. Draw Pele asked for it after having seen my rod. But personally, I've used it maybe once, but I don't use it because I don't think it's necessary. And it adds some difficulties to the surgery, very close to the joint. So I prefer not to use it. And I have seen, particularly in the distal tibia, I've seen that K-wire migrating through the physis because the rod was not telescoping.
I see.
I've seen a case that was referred to me, and personally, I don't think, as I said a moment ago, I prefer to go down to the subchondral bone to have some good purchase for the threads of the male rather than use the small hole. But I know that lots of people prefer to kind of locking the system.
Yes, I have used it only in patients that some surgeon before used that retrograde nail, whatever nail you use it, could be a rush nail, and they put a rush nail retrograde from knee to the head of the femur. I mean, retrograde. So the patient had a hole. So you don't have a place to hold the threads of the fascial rod when you put an antegrade. So in this case, maybe I have like 3 patients. I use the K-wire to hold the fascial wall. It's the only cases I use it. Even I don't use it in congenital osteoarthrosis of the femur. I use the normal threads also.
That's good. I think we reached the conclusion of this fruitful session. Thank you very much. Thank you, Dr. Miguel. Thank you, Dr. Faser. We appreciate your presence. And Dr. Miguel, we'll see you on the next Monday, 11th of May to 2020, and the same time of this.
Okay, thank you. Those are
thank you very much.
Nice to see you. Pancho.
Thank you, Miguel. Take care.
Okay.
Thank you. Bye-bye.